Hi, welcome to my presentation on the grief and trauma of stillbirth and infant death. I'm Dr. Ivy Love Margulies. I'm a clinical psychologist and death midwife who specializes in grief, loss, and trauma, encompassing the entire spectrum of women's maternal health. In my unique way, I blend psychology, ritual, spirituality, Reiki, energy healing, meditation, and more to help facilitate and support women, couples, and families going through the grieving process. In today's modern world, there's a massive void for support and practical information to help soften the pain of unimaginable loss. This is why I developed this training to help guide and educate clinicians, midwives, doulas, medical professionals, nurses, anyone in the healthcare field who would like to know more about how to help women during the most unfathomable loss of their lives. Approximately 1/3 of all pregnancies will end in a miscarriage, stillbirth, or termination. Stillbirth and infant loss is significantly correlated with a higher incidence of a diagnosis of PTSD, post-traumatic stress disorder, and/or a postpartum mood and anxiety disorder. PTSD has historically been associated with veterans, horrible car accidents, and patients in the intensive care unit, for example. PTSD is also a common diagnosis for birth trauma. I hope this presentation will not only help educate you to the most common loss women have during their reproductive years, but also how to mitigate the trauma and long-term negative psychological symptoms associated with perinatal loss. Bereaved parents will never forget the understanding, respect, and genuine warmth they receive from caregivers, which can become as lasting, as important as any other memory of their lost pregnancy or their baby's brief life. I've broken down the presentation into modules that can focus on specific topics. As you go through the presentation, take notes and reflect upon the information given, and feel free to email me at ivy@drivylove.com with any questions. I will be more than happy to get back to you. Let's go ahead, get started, and I know this presentation will be of use to you and anyone you work with. Namaste. Hi. Welcome to my presentation on the grief and trauma of stillbirth and infant death. Module 1. The typical timeline after a woman finds out her baby has died, statistics, types of perinatal loss, and frequency. Typical timeline after a woman finds out her baby has died in utero. Usually a woman is alone at this prenatal visit. It may have been already scheduled, or she may have shown up in the office because she's a little nervous, she hasn't felt the baby move recently, she may be experiencing some preterm labor, maybe she's just having an intuitive sense that maybe something feels a little different. After the doctor has performed an ultrasound and has said the words, "I'm sorry, I cannot find your baby's heartbeat, your baby has died," her world has just blown apart. She will be in shock. It will all seem surreal. She will not even probably accept what the doctor's saying. She will have to call her partner, husband, family member, or friend to come and get her because she is alone and cannot drive. Her doctor will then inform her to either go home and get some things or go straight to the hospital and get checked in and be induced. Generally, a cesarean section surgery is not offered unless the baby is breech or there's a medical condition that warrants that the mother have a cesarean. So she will be having to birth and labor her deceased baby. Labor can last longer than normal because she's birthing in fear, grief, and profound sadness. Fear alone will keep her from allowing her body to open during labor, and it is also obviously not her birth experience that she was wishing for and hoping for to have. Often, women and their partners are not offered the option to take their baby home and have a home funeral after they birth their deceased infant. This is a beautiful and loving option to say goodbye to a beloved baby. There is a phenomenon called empty arms, that when a woman leaves the hospital without her deceased baby, she will actually feel an aching in her arms, a physical reaction to not actually holding her baby. Additionally, along with the falling hormones and the postpartum and even lactation, she will be dealing with the physical sensations and healing of her body, as well as trying to integrate what just happened through a birth trauma. So she will be experiencing PTSD, postpartum, and grief. It is indeed a very complicated mental health picture. The definition of perinatal loss is most often defined as the non-voluntary end of a pregnancy from conception, during pregnancy, and up to 28 days of the newborn's life. There are many different types of perinatal loss. Ectopic or tubal pregnancy is especially dangerous for the woman. She could die. It is life-threatening. She could lose a tube, and it is extremely painful. A chemical pregnancy is when the egg does not implant properly but raises the HCG levels, so she will get a positive pregnancy test, but again, the egg will not implant. A blighted ovum is when the sac implants but the embryo does not develop. A miscarriage is when a woman loses her pregnancy prior to 20 weeks gestation. And a stillbirth is when a woman loses her pregnancy post 20 weeks gestation. Neonatal death is birth up to 28 days of life. Every year, 26,000 babies die of stillbirth. To compare, 2,500 babies die each year of SIDS. Perinatal loss occurs in almost 2 million women a year. There are 6 million conceptions reported, and of that, 2 million are miscarried or terminated. Up to 25% of all conceptions end in miscarriage. 1 out of 4 women will have a miscarriage. 1 out of 2 will have an abortion or termination, or I like to call them a pregnancy release. There is a stillbirth every 21 minutes in the United States, or 70 stillbirths every day. In California alone, there are over 500,000 babies born. California has the largest birth rate across the whole United States. In descending order, it's California, Texas, and then New York. Stillborn babies account for nearly 75% of all perinatal deaths. Unexplained stillbirth is nearly 10 times more common than sudden infant death syndrome or crib death. And globally, about 3 million babies a year are stillborn. Again, here's a graphic on the birth rates across the United States. Cultural statistics on perinatal loss and preterm births in California. In 2012, almost 10% of the 500,000 babies born are born before 37 weeks gestation. The highest rates of preterm births are among Black moms, followed by Hispanic and Native American women. The lowest preterm birth rates are to Asian and white mothers, and Black women are twice as more likely to have a stillbirth than a white woman. African American women experience all types of pregnancy loss more often than white women. The study in 2009, sponsored by the National Institute of Health, found that Black women were more than twice as likely to have late pregnancy loss, including stillbirth. That study attributed the difference to higher rates of pregnancy complications like diabetes, high blood pressure, premature rupture of membranes, uterine bleeding, placental abnormalities, and problems with the umbilical cord in labor. Once again, we don't really understand why Black women experience higher rates of those complications. Lupus is more common and severe in Hispanic women than in women of other racial groups in the United States. But some studies suggest that genetics and factors related to socioeconomic status, such as diet and stress level, may play a part. Lupus and any autoimmune disease needs to be managed during pregnancy to ensure that the woman does not have a preterm infant or a stillbirth. Common known causes of stillbirth. The pie chart on your right does break down the common known causes. Placental abruption. Preeclampsia is a pregnancy-related form of high blood pressure. There is also pregnancy-induced hypertension. Both increase the risk of placental abruption and or stillbirth twofold. Chromosomal disorders account for 15 to 20% of all stillborn babies. Bacterial infections between 24 and 27 weeks can cause fetal death. Maternal diabetes, kidney disease, and lupus also all increase the chances of having a stillborn baby. As you can see from all of these possible contributing factors, it's really important for a woman to start her prenatal care early so that any of these risk factors can be addressed and managed. After a second trimester loss, all patients warrant a thorough history and physical examination to look for factors that may predispose them to another loss. Ideally, this workup should be done during preconception counseling. The history should include chronic maternal medical conditions that may contribute to pregnancy loss, family history that suggests genetic problems, medication use as an indication of underlying illness, environmental exposures, substance abuse, trauma, and obstetric history. A detailed review of the pregnancy should be performed, including vital signs, weight gain, and lab tests. If the woman has experienced a stillbirth, a pathologic examination of the fetus, of the baby, and the placenta is strongly suggested. Chromosomal or DNA analysis should also be performed if possible. Cultures should only be ordered if the patient has clinical symptoms of a specific infection. This ends Module 1 on the typical timeline after a woman finds out her baby has died, statistics, types of perinatal loss, and frequency. Please continue on to Module 2, where I will discuss grief and issues specific to perinatal loss and possible comorbid diagnoses.